Hello and welcome to the CSF Rheumatology Author Interview Podcast. My name is Professor Peter Nash from the Griffith University in Brisbane. And today we're very fortunate to have with us Professor Roy Fleischmann from the University of Texas Southwestern Medical Center in Dallas. Welcome, Roy, and thank you very much for giving up your time.
Thank you, Peter.
Roy, tell us a little bit, before we get into this article, how the COVID situation is where you're working, and maybe a bit of how it's affected the way you can work.
Yeah, so that's a very interesting question. So as you know, I'm spending much of my time now in research in our unit. Our unit is divided into two. We have the research unit, and we have the practice. What's happened in the practice has been, although we've been open all the way through COVID, we find that there are many patients who are unwilling to come in. So we're down probably 30–40% in patient visits. And that means that we're doing more telemedicine. And telemedicine, although there are great proponents of it, as we both know, it does lack. You can't see a patient, you can't examine a patient, and certainly you can't get laboratory. So these are some of the problems that we have. And interestingly, we're not seeing new patients. And we're not seeing new patients because patients aren't going to their primary care physician when they have symptoms, and they're not being referred.
And just a little bit about yourself for the audience. Most people know you, Roy, but just a little bit about your background, where you trained, how you came to be where you are, and your particular interests in rheumatology.
When I was at Columbia, I was recruited to Dallas by Mars Zeff, who many people remember, because during my fellowship, and well, I was on staff at Columbia as well, I was doing clinical practice, but also doing clinical research. And what Mars needed was, he needed clinicians, because he had a very good basic laboratory, and he was very interested in clinical research. So I came to Dallas actually by airplane. I kind of remember what they were like, and was on the campus of the university, taught at the school, opened a private practice, and started a research center. And this was in the late 1970s. And that's where we've been in Dallas.
Talking about clinical trials, we've found there's a big hole now in collecting data on these patients in all these trials that'll be sort of 3 to 6 months long, where they're not coming in to be examined and they're not getting their bloods. It's going to be a nightmare to assess these trials.
Well, in the States, our unit has remained open, and we have seen patients who were enrolled in trials. We've seen all the patients enrolled in trials. We had holds on many of the protocols for new protocols, which just didn't start up, or we didn't recruit new patients into studies. It was patients who were already in the studies. So we do have the data.
But just as well, because it's going to be difficult otherwise.
Yeah, but it's slow.
Okay, so let's talk about this particular study that was recently published in Arthritis Care and Research in the August edition, which is looking at the long-term extension of RA Begin. So perhaps if you just mention a little bit about what RA Begin did.
Okay, so let me talk a little bit about Bari first. So Bari is a JAK1/2 inhibitor, which has shown efficacy both as monotherapy and in combination with conventional synthetic DMARDs in patients who are methotrexate naive or conventional synthetic DMARD IR or biologic DMARD IR, and was found to be superior to adalimumab by ACR metrics in a head-to-head study. Bari does improve patient-reported outcomes and inhibits radiographic progression. 2 milligrams is the approved dose in the US and Canada, but both 2 and 4 milligrams are approved in many countries around the world. In this study, which was RA Begin, what we did was we took patients who were methotrexate naive and treated them either with methotrexate up to 20 milligrams a week, or baricitinib 4 milligrams monotherapy, or baricitinib plus methotrexate. And that was in the base study at RA Begin. And the result of that study was that baricitinib monotherapy and the combination therapy looked to be equally effective clinically and functionally and better than methotrexate. But in terms of radiographic progression, only the combination was superior to methotrexate, not the monotherapy. As part of this study, the long-term extension, the immediate long-term extension was to take patients from the primary study and put them all on baricitinib monotherapy 4 milligrams. Everyone went on 4 milligrams. So methotrexate went to Bari 4, Bari plus methotrexate went to Bari 4, and the patients on Bari 4 maintained Bari 4. And so what we were looking at was whether or not you can maintain efficacy with Bari 4. And did it do better than methotrexate, and so on and so forth. What we found was that indeed, many of the patients who were on methotrexate who went to baricitinib 4 milligrams monotherapy actually did better. And many of the patients who were on the combination did well with monotherapy. And patients on the monotherapy continued to do well. Part of this protocol, though, was that the physician, he or she could add methotrexate to the monotherapy at their discretion. There was no criteria for it. And about 50% of the patients in all 3 groups, the patients who were methotrexate went to Bari, the patients who were Bari monotherapy, and the patients in combination went to Bari monotherapy, added methotrexate. We analyzed that group of patients and what was the difference? What was the difference in the patients who added the methotrexate? And it turned out that the patients in the primary study who were doing relatively well when they went into the LTE actually didn't have methotrexate added. It was the patients who had the higher CDI, higher SDI, who, when they went to monotherapy, still didn't do as well. And then those were the patients that had methotrexate added. So
can you remind us, sorry,
yeah.
we'll come to the conclusion. Can you remind us, Roy, about the CDI and SDI and why that was important in JAK studies for the audience, please?
Yeah, so I'll remind you, because you probably forgot it, but the JAKs can and do affect IL-6. IL-6 is a key cytokine in terms of CRP. So if you're looking at a DOS28 CRP, you can get a better result in the DOS28 when you use a JAK just because of the effect of the IL-6, and it's just because of the effect on the CRP. So in this study, we actually used the CDI. So there was no CRP that was involved. We used the CDI as our primary endpoint.
Right. And look, the CDI is popular in Europe. I always thought the US was a rapid 3 country. Can you tell us, is CDI being used in the US? It's certainly not being used routinely in Australia.
Yeah, so in my group, everybody does a CDI. Everybody does a CDI. I actually also do DOS28 because I've been doing it for years, but it's a DOS28 ESR, not a CRP. But nobody else, I think, does a DOS28 ESR CRP. We look at RAPID-3, but RAPID-3 is really a patient-reported outcome. It's not the same as the CDI. It is the clinical. So I look at the CDI and the RAPID-3. In the U.S., there are many rheumatologists who use the RAPID-3 because the patient fills it out. It's easy to get
in the waiting room.
Yeah, yep. The waiting room. It's easy to get the data. But as you know very well, because we've talked about this, even though they get the RAPID-3 or they do a CDI, maybe they'll respond to it or not. So it really is problematic. But the CDI is becoming more and more popular in the US.
And can you tell us a little bit about which of those patients you would be suggesting, let's go combo rather than mono, based on some of the results of this study? The X-ray, we understand there is an advantage of combo over mono. Is there anything in the baseline characteristics that said, really stick to combo if you can? Because just looking at the tables, it appeared the people with the CDIs around 10, about half of them wound up on methotrexate, whereas those with the CDI around 2.8 or 3, not that higher percentage changed over. So is there any sort of baseline characteristics that might help the clinician?
Yeah, so the baseline characteristic in this long-term extension, right,
Sure.
is that the patients who continue to have disease activity should have modification of their medication.
Right.
The baseline characteristics in RA Begin, when we started the study, you couldn't tell who would do what. But as you know, Peter, I know you know this quite well. What this study has shown, we've shown the same thing with tofacitinib and oral strategy. We've seen the same thing with filgotinib, actually, in their studies. We haven't seen it with upadacitinib because they haven't done the study.
Sure.
But with each of the three drugs that have done the study, it turns out that patients on combo generally do better than patients on mono, but there are many patients who do well on mono. So what I do in my practice and what I teach is you're going to start with methotrexate because it's cheap and that's the drug you're supposed to use. And if the patient doesn't achieve the goal of therapy, which is remission or maybe very low disease activity, add the JAK. Add the JAK. And then when they achieve what you're looking for, what the patient's looking for, then try and get rid of the methotrexate. And in my experience, I think what this study showed, which was 50% of patients were able to discontinue methotrexate. I've shown with tofacitinib about 70% of patients were able to discontinue methotrexate. The true number is somewhere between those two. So many patients can't discontinue. But I would not start with the mono if the patient can tolerate methotrexate.
Methotrexate. And were you able from this particular long-term extension to see those people who went to mono, restarted MTX, you could recapture them? Was that able to be shown?
Yes, we discussed that. Yeah, we discussed that in the paper as well.
Okay, so that's a big advantage. Now, safety, of course, is critical. That's black box about VTE, led to the 2 milligram dose. Can you just comment on a little bit on the 2 milligram dose and how it's being used in the US, and then maybe safety from this long-term extension?
It's used in the US and it isn't used very much.
Okay.
So what's problematic here is that the 2 milligram was in 2 of the 4 studies that Lilly did with baricitinib. But in both of those studies, the 2 milligram actually worked. It didn't work quite as well as the 4, but it did work. It worked in TNF incomplete responders and conventional synthetic DMARD incomplete responders. So we do have patients that we treat with 2 milligrams, and there are patients who do well with it. In the US, we have an unusual health system in terms of medication, where the insurance companies will tell you, you must start here or must start there. It turns out that upadacitinib, because AbbVie also has Humira, right, adalimumab,
Yep.
is attractive to many of the insurance companies because of the rebates they get or the discounts that they can give. So it isn't the preferred drug by some insurance companies, but the 2 milligrams does work, but it isn't used as much. And I think that in the rest of the world, that's what I hear too when I speak to you or speak to Professor Tanaka from Japan or speak to Joseph Smolin from Vienna. It's usually the 4 milligram, and then you go to the 2 milligram if the 4 milligram worked very well, or an older patient, a patient with renal disease.
And so many clinicians are worried about the VTE. Is this a JAK2? Is it a class effect? Firstly, your thoughts on that issue, and then maybe any VTE, any zoster, any signals coming up in the long-term extension to guide us with safety with baricitinib.
So that's a very complicated question. Let me answer the second part first. So in the long-term extension of baricitinib, where they had both 2 milligrams and 4 milligrams in RA Beyond, the events, the VTE events, were exactly the same with 2 and 4 milligrams. There was no protection at 2 milligrams versus 4 milligrams. When the FDA made its determination, they made it only on the first 12 weeks placebo-controlled, where there were no VTEs with 2 milligrams, and there were 4 with the 4 milligrams. But that was a very convoluted, questionable decision. The question about whether VTEs are really related to JAKs or they're related to all of our medications or related to RA, it's really not clear in my mind. When we went through the Treg analysis from EULAR, there was a very interesting abstract coming from Sweden, which has a really good safety database, where it turned out that the VTE was related to disease activity. And patients at high disease activity had twice the risk of developing a VTE versus somebody who didn't have disease activity. So I think this whole question is very complicated. And I'm not sure that the JAKs, in spite of the FDA, in spite of the EMA, really increase the risk that much. They may, but I don't know that we have all the answers yet. And if they do, we don't know why they do.
Sure. So the safety, any safety information from the long-term extension that you can help?
There was nothing that occurred in the long-term extension that we didn't know before. You did get an instance of herpes zoster. There were a few VTEs. You can get elevation of lipids. You can get neutropenia.
But it always seems a combo has a touch more SAEs than the monos or the MTXs.
Because of the MTX. Now you have MTX plus the JAK. So that's very true. So liver function test abnormalities are much higher in combinations with any of the JAKs than the monotherapies. It's one of the reasons why I like the monotherapy. Patients like the monotherapy for lots of reasons.
Okay. So your conclusions from the study and a take-home message for the clinician.
So my conclusions from the study was if the patient does well on 4 milligrams mono, they will probably continue to do well on 4 milligrams mono. If they're doing very well on the combination, you can certainly try and do the mono. If the patient's on methotrexate, not doing quite as well, they might do better on baricitinib 4 milligrams mono. My take-home message is I do think that baricitinib is a worthwhile drug. I think it's quite effective. I would add baricitinib to methotrexate and then try and reduce it. And I think you'll be successful at least 50% of the time.
Excellent, thank you. So if in the future, looking into your crystal ball and generic JAKs are very cheap, can you see the day when JAKs come first rather than methotrexate?
So you hit the nail on the head. It's the cost. The JAKs are generic, and the JAKs are relatively cost effective, and patients have access. There's no doubt in my mind that I would start a JAK before methotrexate. Methotrexate has a lot of side effects. There are tolerability issues, but also adverse events that occur. And each one of the JAKs, baricitinib, tofacitinib, upadacitinib, I think even filgotinib, has demonstrated that they are superior to methotrexate clinically and functionally. So yeah, I would start with a JAK rather than a biologic, for sure. And I may start with the JAK 5 to 10 years from now over methotrexate.
Whenever I ask that question to our Viennese friend, he says, no study's ever been done, JAK or any drug versus MTX plus low-dose prednisone. And you've never shown that you've beaten that combination. But I think that's responsible for a very wide and persistent use of low-dose prednisone, even though the guidelines say to wean people off. I have great trouble getting them off the last few milligrams.
Yeah, so that's the issue. The issue, and I've heard that from our friend in Vienna as well, many times. But he doesn't seem to be concerned about using 5 or 10 milligrams of prednisone a day. My patients are. I may not be concerned if it was 2 milligrams of prednisone, 3 milligrams, but I'm not even sure that 5 milligrams is safe. And you're exactly correct. But the EULAR recommendations and the ACR guideline both say that you can start with it and get it off in 3 months, or if you use it for a flare, use it for a short term, But that's not true in practice. So we see that in trials all the time. When you take a look at the background use of prednisone in trials, so these are patients with very active disease, obviously, but it's 50-60% on prednisone. And then you take a look at the dose, the mean dose is like 6.5 milligrams, 7 milligrams. So we're not talking about 1 or 2 milligrams. I agree with you, but Joseph is correct. We don't have that particular trial.
Yes, and I don't think we ever will. So thank you very much again for your time, Professor Fleischmann. This has been the CSF Author Interview Podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, you can find detailed slide sets available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever you get your podcasts from, and give us some feedback and let us know what you think. Thank you so much, Roy.
Thank you, Peter.